So there are two types of aortic aneurysms. We can have thoracic and we can have an abdominal aortic aneurysm. They have different epidemiological facts and associations that you have to know. We're going to discuss these in depth. So your exam isn't going to ask you about an asymptomatic aneurysm. The management of an asymptomatic one is more a step 2 question. You need to be able to identify a patient that comes in with symptoms of an acute problem and then identify the underlying disease. So these people are going to present in pain. The pain is due to the stretched aorta pushing on surrounding structures and nerves. Or in the case of a rupture, blood can directly irritate nerves. Now in a rupture, the classic vignette is an elderly male with a long history of smoking presenting with a pulsatile abdominal mass. Low blood pressure, hypotensive because of bleeding into the retroperitoneal space. The blood is causing irritation of nerves, creating pain. Here we have a CT scan showing us a cross-section of someone's aorta. Now after describing an older male smoker with vague abdominal pain, you can see the CT scan of the abdominal aorta below the level of the renal arteries. Remember, it is particularly susceptible to atherosclerosis because there is no vasa vasorum within the adventitial layer of the aorta below the renal vessels. Why does that increase the risk for aneurysm formation? Because oxygen and nutrients now must diffuse through the intima, the media, and the adventitia all the way from the vessel lumen. If you have vasa vasorum in the adventitia, blood can also be provided from the vasa vasorum to the rest of the vessel wall. But when you have atherosclerosis and you have very thick fibrous cap blocking the diffusion of oxygen and nutrients, you're going to increase the risk for atrophy of the 3 layers of your vessel wall. All right, so what is the difference between abdominal aortic aneurysms and thoracic aneurysms? So the thoracic aorta is right where we leave the left ventricle and we're pumping blood at its highest pressures into the aortic arch. And it just comes down and then it'll cross the diaphragm. Thoracic aortic aneurysms are often associated with hypertension, unless the person is really young, in which you need to worry about a connective tissue disease. Which ones are we worried about? Marfan's and Ehlers-Danlos. There's also a classic association of tertiary syphilis. Tertiary syphilis is rather rare these days, but that makes it even more fair game for your step 1 exam. Now the spirochete treponema pallidum can end up in the vasa vasorum of the thoracic aorta. This is an electron micrograph of a biopsy taken from the vasa vasorum of a patient with tertiary syphilis and cardiac manifestations. So the spirochetes are literally inside of the vasa vasorum. The vasa vasorum are supposed to supply the thoracic aorta. This is a problem. Our immune system is going to start attacking these spirochetes. And guess who also is going to be attacked? The vasa vasorum. So this inflammation is going to close off the lumens of the vasa vasorum. That's going to severely decrease the amount of oxygen and nutrients the vessel is going to be distributing to the adventitial layer and the medial layer of the aorta. The end result is a very weak vessel wall susceptible to aneurysmal dilatation. Your book says that thoracic aortic aneurysms are associated with cystic medial degeneration. Now, what does this term even mean? Okay, so what's going on is that there's degeneration of elastin and vascular smooth muscle cells. This degeneration is going on in the media of the vessel wall, and when the tissue degenerates, it's replaced by cysts. So they describe this term for this reason, and it's classically seen in people with connective tissue problems. Aortic dissection is incredibly high yield. This actually happens to people a lot. The white arrow here on the diagram is pointing to the initial longitudinal tear through the intima. So the intima is the white layer, the yellow layer is the media, and the outer green layer is the adventitia. So again, the white arrow shows a tear through the intima, and now blood is accumulating in the media. This creates a false lumen. We call it a false lumen because there's going to be blood traveling in a space that is not lined with all 3 layers of the vessel wall. Now, you need to watch out for this in patients with hypertension, bicuspid aortic valves, and then someone that might have Marfan syndrome or Ehlers-Danlos syndrome. The presentation of aortic dissection is always going to describe sudden onset tearing chest pain. As you can see, this gentleman here is experiencing that sudden onset tearing chest pain. This pain will always be described as radiating to the back. The other signs of an aortic dissection will be unequal blood pressures in the arms and a risk for pericardial tamponade, depending on what type it is, A or B. So this is type A, and A is for ascending. The aneurysm involves the proximal part of the ascending aortic arch. These tend to be very unstable, not good, and they can increase in size or even extend proximally or distally, like you can see here. The tear continued and extended all the way down around both sides of the aorta. This is why type A requires surgery. You do not want the dissection to extend distally or proximally. Now, dissection towards the aortic root in a backward fashion is possible because the adventitia of the aorta is continuous with the epicardium. Why is this dangerous? Is it a problem? Yes, it is. Because if this blood travels in a retrograde fashion towards the pericardial space, what's going to happen? This could happen. So now we not only have an aortic dissection, but we've progressed to tamponade because the blood is collecting in the pericardial space. Another potential situation that can come up is not type A, but type B. So this occurs beyond the ascending aortic arch. Usually it will only involve the descending aortic arch or the descending aorta itself. These tend to be more stable and can be controlled with a beta blocker. You also give them a vasodilator to decrease some of the pressures in the aorta. This management decreases wall tension and hydrostatic pressure within the aorta and the false lumen. One quick thing to remember though is that both types A and B have the risk of potentially compressing the left subclavian vessels. Both types A and B of aortic dissections have the potential to compress the left subclavian vessel, which is particularly high yield. This leads to uneven pressure readings in the upper extremities because the right side can be unaffected while the left side is being compressed, and there's decreased blood in the arm leading to a decrease in blood pressure while there's no change on the opposite side. Alright, now we move on to ischemic heart disease manifestations, starting off with angina. So anginal pain is just like any other type of cramping muscle pain. Angina is literally Greek for strangling, which is exactly what's happening in ischemic heart disease. The myocardium, subendocardium, and other layers of the myocardial wall are being strangled for oxygen. There are 3 types that you need to be aware of. Now in stable angina, the myocardium is being strangled of oxygen because of a stable atherosclerotic plaque, preventing adequate perfusion in times of increased demand, such as exercise. This is only transient ischemia of the subendocardial layer. This is during times of increased demand, such as exercise, so look for the vignette to mention resolution with rest. That is incredibly important. On the ECG, or electrocardiogram, look for signs of ST depression. These patients feel better when you give them something to help that coronary artery bring in more blood. So you give them something like nitroglycerin and they feel better. Or if they're resting, they feel better. Now what about Prinzmetal or variant angina? This is transmural ischemia or transmural strangling due to coronary artery vasospasm. This leads to ST elevation because the entire wall goes ischemic. Watch out for an identifiable trigger such as tobacco, cocaine, or triptans will have to be in the vignette to allow you to click this as the answer. Now cocaine leads to very, very powerful vasoconstrictive effects, which is why chronic users can suffer nasal septum perforations secondary to the vasoconstriction-mediated ischemia in their nose. So look for signs of cocaine intox or something with the nose, such as septal problems, to tip you off if the etiology is cocaine. Now, triptans are serotonin agonists, and this causes vasoconstriction of meningeal vessels in order to treat migraines. But if you do this in the coronary artery, triptans can induce vasospasm. Now, tobacco smoke is just terrible. It has toxins that directly inhibit endothelial cells from producing nitric oxide. So with less nitric oxide, this means we're going to get vasoconstriction and potentially vasospasm. So how do you treat this? First of all, take away all of these triggers and give a calcium channel blocker to address the spasm. You also need to dilate the vessels with a nitrate so more blood can get in there. Okay, so one left to go. Unstable angina. This is due to an unstable atherosclerotic plaque that's going to rupture. This leads to incomplete coronary artery occlusion from the formation of an acute thrombus. Look out for ST depression and or T-wave inversion. You will not see any cardio biomarkers. Why? Because if you do see cardiac biomarkers such as troponin I, then you have to call this a non-STEMI, which is a non-ST elevation MI or ST elevation MI, if you have positive markers. How do you differentiate unstable from stable? Unstable angina does not improve with rest. So now we go on to coronary steal syndrome. This is high yield. Notice here on the patient left image, there is a large plaque limiting blood flow. This vessel has already used up all of its compensatory mechanisms to maximally dilate this part of the coronary artery because it wants to increase flow past this stenotic branch. So if we give someone dipyridamole or if we give someone regadenoson, we're going to get vasodilatation of all of these vessels, except we are not going to get any more vasodilation of this branch with the lesion. It has already used up everything it can to increase the diameter so that more blood can flow past this lesion. So we want to increase flow past that atherosclerotic impedance to flow, right? Yes, but because this coronary artery branch has already used up all of its ability to dilate, we're going to open up this vessel and open up this vessel, and now we will actually begin to shunt blood away from this stenotic branch. This is the principle behind a stress test in which a patient receives regadenoson, then a nuclear tracer sees which areas of the myocardium undergo ischemia. And the area of the myocardium that will undergo ischemia is the myocardium provided by this stenotic branch, because we shunt blood away from the dilation of all the other coronary artery branches. Now we move on to myocardial infarction. We will really go more in depth in the coming slides about myocardial infarction, but we can take this opportunity to say again that transmural ischemia is going to show ST elevation and subendocardial ischemia is going to show ST depression. Anytime you have cardiac markers as positive, you have to change your diction from angina to STEMI or non-STEMI. So now we move on to sudden cardiac death. So if someone dies within 1 hour of symptom onset and is due to cardiac origin, you call it sudden cardiac death. Most of the time, there's already pre-existing diffuse myocardial abnormalities, such as excessive scar tissue from several infarcts, secondary to coronary artery disease that these people usually have been fighting for a long time. People with scarred myocardiums have areas of tissue that depolarize at different rates. This area of tissue depolarizes in 0.5 milliseconds. And then this area of tissue depolarizes in 1 millisecond. This is how you progress to ventricular fibrillation. There can be a depolarization wave that will hit this adjacent tissue and then it'll loop back on itself. Eventually it'll just continue circling and circling and circling. This is fibrillation. If there is a family history of sudden cardiac deaths, especially in sleep or previously healthy individuals, the vignette is trying to guide you somewhere. you have to think about a hereditary channelopathy such as congenital long QT syndrome or Brugada. And we're going to talk about these, so don't worry. All right, so now we move on to chronic ischemic heart disease. This is the result of repetitive ischemic episodes leading to fibrosis. And the fibrosis is chronic. It's never going to go away. So as a result of this chronic ischemia, we're going to have permanent fibrosis. The term indicates that we just have replaced viable myocardium with scar tissue. Now, scar tissue from the fibrosis is non-contractile collagen. If you accumulate tissue that cannot contract and you accumulate it in places where you used to have normal myocardium, you're eventually going to progress to heart failure. Okay, here we go with another flash quiz. So a very tall and flexible 25-year-old man from a tall family presents for an annual exam. Very rare people actually show up for those. For which vascular lesion is he most at risk? So a couple things here that should get your brain rolling. This guy is very young. He's very tall. He comes from a tall family. So either they are a family of very tall, flexible gymnasts, or they have some sort of inherited connective tissue disorder. So what does this guy have? Most likely, this guy has Marfan syndrome, which puts him at a very high risk for aortic dissection. We can easily visualize in this image the feared complication that can occur in a Marfan patient of aortic dissection. Note the additional false lumen formed that travels next to the descending aorta, which is our true lumen. This 3D image over here shows a Stanford Class B dissection, which is involving the distal part of the arch and traveling all the way down to the renal arteries.